Geriatric oncology integrates care that we learn about from geriatrics, which is dedicated to older patients. And oncology is care for people with cancer. As I was in my training, we really wanted to integrate the care for older adults with the care for people with cancer, because we found that oncologists didn't really attend to issues related to older adults, such as other medical problems, comorbidities, disability, cognitive impairment. And these issues are very important to older adults with cancer and their caregivers. Geriatric oncology has grown tremendously over the last 10 years in terms of the research that is being conducted. When we're taking care of patients in the clinic as oncologists, we are often so focused on the cancer and the treatment that we sometimes don't attend to all of these issues that patients and caregivers really care about. So geriatric oncology really strives to integrate those two fields. We utilize a toolbox called geriatric assessment. Geriatric assessment is a compilation of validated tools that is used to assess geriatric-related domains such as function, cognition, comorbidities. We know that these domains are independently predictive of outcome in older patients with cancer. Meaning, if I use a geriatric assessment, I can better understand risk from treatment than if I don't. In standard oncology practice, we use things like age, comorbidity, and performance status. That's historically what we've used in clinical trials to make decisions for older patients. Over the last 10 years, there has been research that's shown that that is inadequate. For example, patients who have good performance status using oncology metrics often will have cognitive impairment because a performance status measure does not capture cognition. So that impacts outcome, and we should be using a geriatric assessment to assess that. We've just conducted a trial that shows that geriatric assessment can improve communication about age-related concerns between oncologists, older patients with cancer, and their caregivers. This was a large cluster randomized trial done in the University of Rochester NCI Community Oncology Research Program Network that enrolled 542 patients. These are patients that are normally not included on clinical trials because they have other medical problems. We were, however, able to recruit them to this trial because the question was clinically important to them. What we found was geriatric assessment improved communication by increasing the number of discussions about age-related concerns, and also by improving quality of that conversation and oncologists discussed more interventions that could be applicable to older patients with cancer and their caregivers. This is the first randomized study that shows that geriatric assessment can improve patient-centered outcomes. And it should, in conjunction with that recent ASCO guideline, lend support to the fact that community oncology practices should start to integrate geriatric assessment into routine care for older patients with cancer on chemotherapy specifically. As we start to learn more about patients and caregivers, we need to ask them about their experience, integrate their words into our experimental trials, and really think about recruiting patients and caregivers from underrepresented areas to understand the whole experience of cancer for our whole population. So this is why geriatric oncology is important, and we really feel as a community, working with ASCO and the Cancer and Aging Research Group, that geriatric assessment should be incorporated into the clinical care of older patients with cancer.